Okay, so here I'm going to talk about our hypersensitivity reactions just in general, and then we will go through each individual one separately. So hypersensitivity reactions is an older way to describe all the different potential autoreactive type responses, and in general, most responses can fall into one of the four different categories. They are a bit oversimplified because many responses are going to include more than one of these types of hypersensitivity, not just one. But there are some classic diseases that do fall into one of the hypersensitivity reactions, and we'll discuss those. So in general, you have your inputs, which are going to trigger some sort of immune response, and then you have your outputs, which is the actual immune response. And these are referred to as hypersensitivities. And so we have our type 1, type 2, type 3, and type 4. And they're pretty general, but they have some specific meanings. Type 1 is always going to be IgE immediate. Type 2 is always going to be IgG, and IgG is binding to something on a cell. Type 3 is also going to be IgG, but this time it's a soluble antigen, it's not cell-bound, so they're going to form more like immune complexes. And then type 4 is cell-mediated. And these are referred to as delayed type hypersensitivity, similar to the tuberculin skin test. That's a delayed type hypersensitivity. And by cell-mediated, it can be a CD4 T cell or a CD8 T cell that does do this. Now, with respect to infections, it's important to understand that not all infections are going to cause excess damage, such as colds. They're a little bit more of an annoyance than excess damage. And then you have other infections that are going to cause excess damage. Most of these are going to be a combination of the different types of hypersensitivities. You can also have a reaction to self-antigen, which of course we refer to as autoimmunity. And then environmental substances or harmless substances can also cause these hypersensitivities. The most common one we think about is the allergic response, type 1, which you have an allergen. But things like penicillin can also be a harmless environmental substance that causes a hypersensitivity type reaction in some individuals. So an overview of hypersensitivity, again, we have these three antigens. And so with respect to your infectious agents, you have things like influenza, you have SARS-CoV-2, you have bacteria infections, and these can all sort of relate to what's called the cytokine storm. And you also have hepatitis B, which can be an overreaction. And then we have our streptococcus, which is going to lead to a post-strep granulonephritis, which is an immune complex disease. And then you have your environmental stimulus. You can have dust, and dust can lead to an IgE, which will lead to allergies. Or you can have dust plus spores, and that can lead to IgG, or farmer's lung. You can have typical allergens, grass, pollen, and these are all going to be type 1 hypersensitivities, IgE. You can have drugs, penicillin. This could be IgE or G or T cell. You can have small molecules such as haptens. And this can be things like poison ivy. And these are going to lead to a T cell, type 4. For a T cell with respect to drugs, you can live to an idiosyncratic adverse drug reaction. And then with respect to our self-antigens, you could have an auto reaction, and to some level in our bodies that is normal. But if you have an exaggerated, this leads to autoimmunity. So one way to think about this is if you have an infection, for example, you're going to do a lot of tissue destruction. And a lot of self-proteins will be released, picked up by macrophages, processed, presented. And these presented antigens might trigger an autoreactive T cell, for example. Or the antigens are released and get into the secondary lymphoid tissue, and they're going to trigger an autoreactive B cell. Now, when everything is all cleared up, those antigens that were released during that pathology stage are no longer present in the circulation, and so those self-reactive cells sort of just go away. They have nothing to respond to anymore. So that's one way to kind of think about that. Now, if you do have a autoreactive response against an antigen that is common and your immune system can see it pretty regularly, then you're going to get an exaggerated response, and then you're also going to get autoimmunity. Okay, so let's go through these individually very quickly and give some examples. So type 1 or immediate hypersensitivity is going to be mediated by the IgE response and mast cells or eosinophils. And again, this is going to occur in seconds. That's why it's called immediate. Some examples are hay fever. We have peanut allergies. We have a bee sting, venom. And you can do a skin prick test to see what allergen you're sensitive to. It can be seasonal. Some schistosomas can have an infectious trigger to this. Environment, of course, are our typical allergens. And IgE does not mediate an autoimmune response. Now our type 2 is going to be cell-associated. This is going to be mediated by primarily IgG. And again, because this is isotype switching, these are all considered secondary responses. So there is a level of memory. And so that is also the case of our type 1. Because this is an IgE, this is also a secondary response. So if IgG is present, the onset can be very quick. And so this is going to lead to some very, some diseases that are going to target specifically our red blood cells. So we can have things called immune hemolytic anemia, and they can have a trigger that is either infectious or environmental. It can also have an autoimmune component. And again, they all have sort of the same target. In this case, they're all going to be targeting the red blood cells. The mediators are going to be complement and phagocytosis. So remember our stories. We have here penicillin, which should not trigger an immune response. It's going to, of course, attack bacteria. However, penicillin can sometimes bind to a protein on some people's red blood cell, shown here. Now, when it binds to that protein on a red blood cell, it's going to look like an antigen to a B cell receptor. Okay. Now, keep in mind this is an IgG, and so this B cell that's binding to this has to get T cell help. So at some point, the T cell has to also be activated against this protein hapten combination. So you'll have CD4 help to that B cell, and you get IgG produced. And of course, this person is not going to stay on penicillin for the rest of their life. And so what's going to happen is everything will go back to normal. The person will be fine. The next time they get infected with the bacteria and they get penicillin again, that's when you're going to get the disease. So the patient will have anti-penicillin antibodies. And these will have nothing to do with a red blood cell that doesn't have penicillin bound to it. As soon as the person takes penicillin again, the penicillin binds to that receptor on the red blood cell again, the antibodies will bind. And then the antibodies will bind to the Fc region of your macrophage, and your macrophage will eat your red blood cell, and this results in anemia. You're going to eliminate your red blood cells. And so again, the antigen in this case is your penicillin binding to the red blood cell receptor. But it's thought that sometimes an infection, such as a virus, can have an antigen that does have a similar effect. All right, so type 3 is also mediated by our IgG. So again, this is a type of secondary response or memory. So in this case, you're going to take a little bit more time, hours, and primarily it's because this is not cell-associated antigen. And so it takes a little bit more time for this to accumulate. So if it's cell-associated, you're basically attacking and killing the cell immediately. If it's not cell-associated, then it's going to have to sort of bind and then get stuck somewhere and then cause some sort of inflammation. So what's basically happening here is that you have some antigen, and in this case they're saying it's a strep protein, so it's a strep antigen. And then you have anti-strep antibodies, and these anti-strep antibodies bind to the strep protein. Now, depending on how much antigen is present, you will have a lot of binding or little. So when you have a lot of binding, you start to get your antibodies clumping together. And then the antibodies are going to clump together and form immune complexes. Okay? And immune complexes are going to get stuck and lodged in small places. They're going to get stuck and lodged into your capillaries. They can get stuck in your kidneys, basement membrane of your lungs. And so they can just kind of deposit, and then they can cause inflammation. So macrophages, neutrophils will come along and try to eat the immune complexes and release all of their nasty stuff into the area, and you can get damage. Hepatitis B, we talked about hepatitis B before, and hepatitis B is that slow guy that will just accumulate, not kill cells, but just keep dividing. And then when it gets released, you have antibodies there that'll bind to a lot of hepatitis B, and you can have the same effect. You can have them binding, cross-linking, getting all tangled up with each other, forming these immune complexes, and then causing inflammation somewhere else because they get released into the blood and then they get stuck in some capillary somewhere. Environmental triggers are going to be what's called farmer's lung, and this is when you're in an environment where there's a lot of fungal spores and there's a lot of dust, and you breathe in and inhale all the spores. So you'll eventually make an immune response to those spores, and then when you get those spores again, your antibodies will bind to them in your lungs, and again you get these immune complex deposits in your lungs. Now the innate mediators are of course complement and neutrophils. So your neutrophils are obviously going to come along and they're going to try to eat the immune complexes. Your Fc region of your IgG are going to be able to activate complement, so you're going to get pro-inflammation, you're going to get your anaphylaxis from aflatoxins, from your complement or recruit the neutrophils and more cells, and you're just going to get inflammation in an area such as the lungs where you do not want it. And then we have type 4 hypersensitivity, and type 4 hypersensitivity is always referred to as delayed because it is caused by T cells. So keep in mind that if it is caused by antibodies, the antibodies, because of your plasma cells, are always present, whereas if it's caused by T cells, there always has to be some sort of period of inactivation. Even though it is going to be a memory type response, it's still going to take time because you have to get the antigen. It has to be presented to the T cell, whether it's a T cell in the tissue or a CD4 T cell in the secondary lymphoid tissues. It still takes a few days. So this is going to be a few days instead of seconds to hours. Some infectious triggers are hepatitis B virus. You also have poison ivy, which is a hapten, and that will cause a CD4 inflammation with your macrophages. We also have, of course, our tuberculin skin test. I'll put that as infectious, even though the antigen's not really infectious, but it's targeting an infection. We have celiac disease, which is a delayed type 4 hypersensitivity, multiple sclerosis, rheumatoid arthritis. All of those are going to be lumped into this. So they all have some sort of T cell component that is causing the symptoms. Okay, and finally we have treatment. So it's important to diagnose these properly because the treatment, of course, is going to be different for the different hypersensitivities. In addition, most of your diseases are going to have overlap. So you're going to have a type 4 with a type 2, for example. These type of hypersensitivities are very simplistic ways of summarizing your immune system, but they can help explain differences to some well-defined diseases. And so we'll continue to explore these hypersensitivities in the coming lectures. Thank you.